This is a young patient presented to us for corneal transplant with a history of eye trauma during the childhood. Apart from the diffuse edema, she also had an anterior chamber IOL, uneven anterior chamber, and pupil descender towards the supranasal quadrant. We removed the epithelium in order to see a bit better through this opaque cornea. And the surgery plan is to perform penetrating keratoplasty and in open sky to explant the anterior chamber IOL and to put another posterior chamber IOL this time, most probably sutured at sclera. First we prepare the graft with desired diameter, and then we cut the host cornea with the Moria trifine. Usually the cut in the host cornea is 0.25 or 0.5 smaller than the diameter of the donor cornea. We take care because we assume there is a vitreous in the anterior chamber and the iris with atrophy areas, and we don't want to pull neither the iris nor the vitreous. You can see here we cut it with the scissors, and now we try to remove the anterior chamber IOL without pulling of vitreous, so very careful. First we perform local anterior vitrectomy just to release the possible vitreous strands which might be pulled when we want to remove this anterior chamber IOL. Again, we complete the vitrectomy in the pupillary area, and with gentle maneuvers we withdraw, we remove this IOL. Fortunately, it was not kept in synechia. It was not too much connected to the iris, like we usually see in cases like this one, with trauma which happened several or tens of years ago, like in this case. Then we continue with vitrectomy in the pupillary area and behind the iris. And by pulling the iris towards the periphery, we notice that the anterior and posterior capsule in the periphery are still there, offering us potential support for a posterior chamber IOL, which might not be needed to be sutured at the sclera as we want it to. So we continue to clean as much as possible the place, and we decided to implant an Alcon 3 PC-IOL MA1680, which will set quite safely on the peripheral capsule remnants, which have been checked previously. But again, by pulling the iris, we want to be sure that the IOL is lying securely in the sulcus on the capsule remnants. And indeed, it looks that it stays quite safe. Our intention is to perform a pupilloplasty to suture the iris in the supranasal area, but at the same time we don't want to pull too much and too dangerously on the iris. We just check if it's possible to suture it, and indeed it seems that we can put 1 or 2 sutures over there. After we cut the sphincter in the inferior part of the pupil, thus we try to relax a bit the pupil and to allow us to obtain a more round and more inferior positioned pupil. As you see here, it seems that the cornea is too much pulled, and this is because we work in an open sky, and of course the IOP is very low. But when we will put the graft, we will manage to restore the anatomy of the anterior chamber and of the cornea, as you will see soon. Viscoelastic in the anterior chamber after we finish the pupil suture. we go to the second step of the surgery, the graft suture. The graft has 4 signs for the first 4 cardinal sutures, as you see. This is very helpful in putting the graft in a precise way and in avoiding the rotation of the graft. Now the graft is sutured with separate 10-0 nylon sutures, and this is how the eye looked 1 month post-operatively and 3 months post-op. A bit later, after we cut some of the sutures according to the topography, 9 months post-op. Thank you.